Hello everyone and welcome to our module on hypoxia. Let's start by talking about oxygen delivery to tissues. As you know, tissues in the human body require an adequate supply of oxygen in order to survive. And the amount of oxygen that is delivered to our tissues depends on the cardiac output, in other words, how much blood flow goes to the tissues, and also on the oxygen content of the blood that's going to the tissues. So in order to have proper oxygen delivery to tissues, you need both a normal cardiac output and a normal oxygen content of the blood. So what determines the oxygen content of our blood? Well, basically, it's dependent on three factors. The first is the oxygen binding capacity. This is how much oxygen the blood can hold, and it's mostly determined by hemoglobin because, as you know, hemoglobin binds oxygen with a very high affinity. So the more hemoglobin in your blood, the more binding capacity of your blood. The second factor is the percent saturation. This is how saturated those hemoglobin molecules are. So even if you have lots of hemoglobin, if very few of them are saturated with oxygen, the oxygen content of your blood will be low. And the third factor is the amount of dissolved oxygen. This is how much oxygen is directly dissolved in your blood. It depends on the amount of oxygenation occurring in the alveoli in the lungs. One of the ways to assess the oxygen content of blood is to measure the PaO2. This is the partial pressure of oxygen in the arterial blood. Because oxygen is a gas, we usually don't measure its concentration in blood in units like milligrams per deciliter. Instead, we measure its partial pressure, but it means the same thing. It's a representation of how much oxygen is present in that blood. And this value is obtained by doing a test called an arterial blood gas. An arterial blood gas requires a needle stick, like is shown here for drawing venous blood. However, instead of sticking the needle into a vein, you stick it into the radial artery and you draw a sample of arterial blood. And from that sample, you can determine the PaO2, and this reflects the amount of oxygen dissolved in the blood, and a normal PaO2 is greater than 80 millimeters of mercury. Another way to assess the oxygen content of blood is through pulse oximetry. This requires the use of a machine called a pulse oximeter that is attached to the patient's body, usually at the fingertip. This will use a photodetector to measure the percent saturation of blood. So now we're measuring how saturated hemoglobin is with oxygen. And as you know, that's related to the PaO2 by the oxygen hemoglobin saturation curve, which I talk about in other videos. So if the hemoglobin saturation is 100%, then you know that the PaO2 must also be relatively high and normal. And then a third way to measure the oxygen content of blood is to actually calculate a number called the O2 content. This number has units of milliliters of oxygen per deciliter of blood, and it can be calculated by determining the O2 binding capacity of blood, which is equal to 1.39 times the hemoglobin concentration. That number is multiplied by the percent saturation, and then finally you add to that a number for the dissolved oxygen in blood. That number is 0.003 times the partial pressure of oxygen. Usually this term is relatively small, so the major determinants of the oxygen content of blood are the binding capacity and the percent saturation. And as I told you before, percent saturation is related to PaO2 by the oxygen hemoglobin dissociation curve. So the key points of this equation that you want to remember are summarized at the bottom of the screen. In order for blood to have normal oxygen content, there must be the presence of hemoglobin. That hemoglobin must be saturated, and in order for it to be saturated, you must have a normal PaO2 because the PaO2 determines the hemoglobin saturation. Let me pause here and review some important terms. You need to understand the difference between hypoxemia, hypoxia, and ischemia. Hypoxemia means a low oxygen content of blood. In other words, a low value for that number we calculated on the last slide. Hypoxia means low oxygen delivery to tissues, and hypoxia can be caused by hypoxemia, but there are also other causes which we'll talk about in a minute. And then finally, ischemia is a special type of decreased oxygen delivery to tissues that is caused by a loss of blood flow. So when the blood in the body has a low oxygen saturation, in other words, a low saturation of hemoglobin or a low PaO2, this is the definition of hypoxemia. And as I mentioned before, hypoxemia can cause hypoxia. However, you can have hypoxia without hypoxemia. In other words, tissues can be deprived of oxygen even when the O2 saturation of blood is normal. So at the bottom of the screen, I've listed common causes of hypoxia. Hypoxemia is definitely one of them, but there are three others that you need to know for the Step 1 exam, and those are heart failure, anemia, and carbon monoxide poisoning. So let's go through those in the next few slides. So the hallmark of heart failure is a reduced cardiac output. This leads to decreased blood flow to tissues, and that can cause hypoxia. This can also be described as ischemia, but it's also described as hypoxia. In this situation, the O2 content of the blood may be normal. Now, some patients in heart failure with pulmonary edema have a reduced oxygen content of blood because of the pulmonary edema. However, heart failure patients who do not have pulmonary edema and are oxygenating normally can still have hypoxia of their tissues, and that is because of the reduced blood flow due to the heart failure. In this setting, the PaO2 and O2 sat may be normal, but there is still hypoxia because of reduced blood flow. So in other words, if you look at this equation at the bottom of the screen, in a heart failure patient who is not in pulmonary edema, the O2 binding capacity of blood may be normal, the percent saturation may be normal, the dissolved oxygen content may be normal, and even the PaO2 may be normal, but the patient can still have hypoxia, and that is because of reduced blood flow. In patients with severe anemia, the oxygenation of blood by the lungs is normal, but the oxygen carrying capacity of blood is reduced because of a lack of hemoglobin. If you look at the equation at the bottom of the screen for O2 content, it is heavily dependent on the O2 binding capacity, which is determined by hemoglobin. So in the setting of anemia, this O2 binding capacity is reduced, and therefore the O2 content of blood is reduced, even though the lungs are working just fine. So if you calculate the O2 content of blood in an anemic patient, it will be low. However, if you measure the partial pressure of oxygen, it will be normal because the lungs are working fine. If you determine the O2 saturation of hemoglobin, that will also be normal because oxygen is binding to hemoglobin normally. There just isn't enough hemoglobin available. And then finally, carbon monoxide poisoning is a special cause of hypoxemia. Carbon monoxide binds to the iron in heme with 240 times the affinity of oxygen. This will block oxygen binding sites in hemoglobin and cause a functional anemia. And this phrase is very important. This is how you want to think of carbon monoxide poisoning. It causes a functional anemia by taking hemoglobin away from oxygen. The alveolar oxygen, in other words, the oxygen content in the lungs, the P big AO2, is usually normal. This is because even though patients are inhaling carbon monoxide, the amount of gas required for poisoning is usually small, so oxygen fills the alveoli at a relatively normal level. Because the oxygen content of the alveoli is normal, that leads to a normal oxygen content in the artery, a P little AO2. However, there will be decreased O2 binding to hemoglobin despite that normal PaO2, and that's because carbon monoxide is blocking the O2 binding sites. So for this reason, the oxygen saturation of blood, the oxygen saturation of hemoglobin will be low. Now, one caveat here, I should tell you that's a clinical point. The pulse oximeter often shows a normal 100% O2 sat in patients who have carbon monoxide poisoning. This is because the pulse oximeter cannot distinguish between hemoglobin bound to carbon monoxide and that bound to oxygen. However, in reality, the oxygen saturation of hemoglobin is reduced. And then if you go ahead and calculate the oxygen content of blood, that is also reduced. So I've summarized the findings of carbon monoxide poisoning at the top of the screen here. There is a normal P little AO2. There's a low oxygen saturation of blood in reality, although there may be a normal oxygen saturation reported by the photodetector. And then finally, all of this leads to tissue hypoxia. So in this slide, I've summarized the causes of hypoxia. In hypoxemia, you have a reduced oxygen content of blood as well as a reduced PaO2 and a percent saturation. In heart failure, the oxygen content, the PaO2, and the percent saturation are all normal. The blood is being oxygenated normally. The problem is blood flow. In anemia, you have a reduced oxygen content of blood because of low hemoglobin levels. However, the PaO2 and the oxygen saturation are normal. And then finally, in carbon monoxide poisoning, the oxygen content is reduced, the PaO2 is normal, and the percent saturation is reduced because carbon monoxide is blocking binding sites for oxygen. And I put a little asterisk here just to remind you that the photodetector may report a normal O2 sat in the setting of carbon monoxide poisoning. Now let's talk about alveolar gas. When you are breathing room air at sea level, the partial pressure of oxygen in the air you are inspiring is about 150 millimeters of mercury. Down inside the alveoli of your lungs, however, the partial pressure is lower. It's only about 100 millimeters of mercury. We call this partial pressure the P big AO2. The big A stands for alveoli. And the reason it's lower than the partial pressure of oxygen in the inspired gas is because gas exchange is occurring in the alveoli. Oxygen is being taken up by the blood and carbon dioxide is being pushed into the alveoli. Now, after oxygen is picked up by blood in capillaries, as I've shown here, it travels to the arterial system where you can measure it with an arterial blood gas. And if you were to measure it, you would find out that the partial pressure of oxygen is about 90 millimeters of mercury. We call that the P little aO2. The little a is for arterial. And the reason it's lower than the 100 millimeters of mercury in the alveoli is because there is some mixing of blood that does not pass through the alveoli. We have some blood vessels in the lungs that travel through the lungs. They do not go past the alveoli, and they mix with the blood coming from the alveoli, and thus you get a slightly diluted and slightly lower oxygen concentration in the arterial blood of 90 compared to 100 in the alveoli. So as I said in the last slide, the partial pressure of oxygen in the inspired air does not equal the partial pressure of oxygen in the alveoli, and this is because gas exchange occurs in the alveoli and there's mixing of alveolar oxygen with carbon dioxide. It would be wonderful if we could sample the alveolar gas and determine the oxygen content, but you can't do that. There's no way to get a sampling device all the way down into your alveoli. But luckily, there is a way to calculate the partial pressure of oxygen in the alveoli using easily obtainable numbers. So if you use this equation shown on the screen here, you can calculate the partial pressure of oxygen in the alveoli. To do that, you take the partial pressure of oxygen in the inspired gas and you subtract the partial pressure of carbon dioxide in the artery, which is easy to identify from a blood gas, and you divide by a number called R. R is the respiratory quotient. It's the ratio of CO2 that's produced divided by oxygen consumed, and under normal circumstances it's 0.8, although it can rise to 1 in settings like exercise. So if you use this equation in a person breathing room air at sea level, the partial pressure of oxygen in the alveoli is equal to 150 minus the partial pressure of CO2 in the artery obtained from a blood gas divided by 0.8. If you determine the oxygen content in the alveoli, you can then determine a very helpful number called the AA gradient. This is the difference between the alveolar and arterial oxygen content, and it's very helpful in evaluating hypoxemia of unknown origin. In order to calculate the AA gradient, step one is to measure the P little aO2 and the P little a CO2. These are both determined from an arterial blood gas test. You then determine the P big AO2 from the gas equation on the last slide. You can then calculate the AA gradient by subtracting the PaO2 minus the P little aO2. And normal is about 10 to 15 millimeters of mercury, and as I mentioned before, this is because some blood bypasses the alveoli and mixes with the arterial blood. There are vessels called Thebesian and bronchial veins which empty into the arterial system, and they bring blood that has not been oxygenated by the alveoli together with oxygenated blood, and they slightly lower the oxygen content in the artery compared to the alveoli, and that creates the normal AA gradient. So if a patient has hypoxemia, meaning a reduced oxygen content of their blood, but their AA gradient is normal, this means their alveoli are working. The problem for this patient is that the patient is not inhaling enough oxygen. So this can be seen with any form of hypoventilation. If there is a reduced respiratory rate or reduced tidal volume for any reason, that can lead to hypoxemia with a normal AA gradient. So things that can cause this are high dosages of narcotics, which can suppress the respiratory drive, neuromuscular weakness, which blunts the ability to take in a breath of air, or obesity. You can also see hypoxemia with a normal AA gradient at a high altitude. At very high altitude, there's a low partial pressure of oxygen, so even though the alveoli are working, it can lead to hypoxemia despite a normal AA gradient. And all these forms of hypoxemia with a normal AA gradient can be treated with more oxygen. That's because the alveoli are working just fine, and so if you push more oxygen into the lungs, you will raise the oxygen content of the blood. In contrast, when there's hypoxemia with a high or increased AA gradient, this means something's wrong with the alveoli. They're not working. Either they can't get oxygen to the blood, or the blood is not going to working alveoli. And most lung diseases have a high AA gradient, diseases like pneumonia and pulmonary edema and many other lung diseases. And we'll talk about in the video on VQ mismatch that there are three basic mechanisms that cause hypoxemia with a high AA gradient. Those mechanisms are fibrosis, shunt, and VQ mismatch. And anytime you see hypoxemia with a high AA gradient, these are one of the mechanisms that may be leading to that pathology. And that concludes our video on hypoxia.